Today we will try to discuss about nystagmus, which is a bit a complicated topic. Coming to the definition, it is a spontaneous involuntary eye movements, most typically in the form of repetitive oscillations of the eye, and it can lead to oscillopsia, which is a subjective sense of visual motion. One of the closest differential for nystagmus is saccadic intrusions. So to differentiate both, nystagmus will be rhythmic regular, whereas saccades will be non-rhythmic. And nystagmus is continuous and sustained, whereas saccades will be intermittent in nature and it will be unsustained. One of the important feature is the initiation of the shift is slow in nystagmus, whereas initiation of shift is fast in saccades. We can see some videos to differentiate nystagmus and saccades. So here the eye movements are rhythmic, regular and continuous, and the fast component is and the initial shift is slow. So this is nystagmus. Whereas in this one we can see the eye movements are irregular, non-rhythmic and non-sustained, and the shift of the initial shift is fast. So this is saccade. And when we read about nystagmus or saccades, it is very important to understand the mechanism of control of eye movements. So there are few structures which will control the eye movements. For example, for horizontal eye movements, the structure called as, which is shaded in the blue here, called as parapontine reticular formation, PPRF, is the structure which will control horizontal eye movements. Whereas for vertical eye movements, the structure which is shaded in red color throughout, which is rostral interstitial nucleus of MLF, which will control the vertical eye movements. So these two structures are very important in the control of eye movements, and others are vestibular system and cerebellar system. These two are also involved in the control of eye movements. So any damage to these structures which will lead to the abnormal eye movements, which we call either nystagmus or saccades. Then coming to the approach to nystagmus. So what we have to do is, first we have to assess whether the nystagmus is gaze evoked or is it present in the primary vision. So any nystagmus which is in primary vision is always pathological, whereas suppose the nystagmus is only gaze evoked, then we have to assess whether it is physiological or pathological. So the differences are, physiological gaze evoked nystagmus will be present only in extreme right or left gaze, and it is poorly sustained, and it will fatigue over time, and it will have small amplitude, and it will be only either right or to the left, and it will never be up gaze. Whereas pathological gaze evoked nystagmus will be present in less than extreme gaze, and it will be sustained and will have large amplitude, and it can present in up gaze. Here we can see gaze evoked nystagmus. So after differentiating the gaze evoked nystagmus as physiological and pathological, then we have to look for the type of nystagmus. So whether it is jerky in nature or pendular. So what is the main difference is, pendular type of nystagmus will be crossing the midline equally on either side, whereas jerk will be present on one side and it will never cross the midline. We can see some examples. So this is the pendular type of nystagmus. It is crossing the midline, whereas this video which we saw previously is jerk type. It is not crossing the midline. So once we decide whether it is jerk or pendular type, then we have to find out the trajectory. That is, based on the fast phase, nystagmus can be classified into downbeat, left beat nystagmus, right beat nystagmus, or upbeat nystagmus, etc. So the trajectories commonly found are horizontal or vertical or tractional type. Horizontal trajectories can be because of peripheral nystagmus or because of the central nystagmus. So to differentiate both, in peripheral nystagmus it will be usually horizontal, whereas in central type it will be either vertical or torsional. One more important difference between peripheral and central nystagmus is peripheral nystagmus will be unidirectional always, whereas central nystagmus will be bidirectional in nature. So here we will see some of the trajectories. Here the fast phase is towards down, so this is called downbeat nystagmus. Here we can see torsional type of nystagmus. So this is horizontal type of trajectory. Again, this is a horizontal trajectory which is seen in the primary vision itself, primary gaze. So this is about the nystagmus approach. Whereas whenever we see irregular, non-rhythmic, intermittent type of eye movements in which the initial shift will be fast, that will be considered as saccade. So what we have to do is we have to carefully observe for the interval, whether there is any interval in between or not. If there is interval in between, which is commonly seen in the square wave jerks, if the interval is not there in between the saccades, that will be either ocular flutter or it will be opsoclonus. We can see the examples here. So in this video we can carefully observe that it is a square wave type of saccade. Whereas this is ocular flutter, and here we can see that there will not be any intersaccadic interval. But the important difference from opsoclonus here is that direction will be usually in the horizontal plane, whereas this is opsoclonus. Here the direction can be in any directions. So this is about saccades. Finally, to summarize abnormal eye movements approach, first we have to decide whether it is nystagmus or saccade based on the regularity, rhythmicity, continuity and the initial shift. Once we decide it as nystagmus, we have to look whether the nystagmus is present in primary gaze or is it only gaze evoked. Suppose it is present in primary gaze, it will be always pathological. And if it is present in gaze evoked type, we have to differentiate whether it is physiological type or pathological based on the extent of gaze evocation, that is the extremity level and the amplitude, and whether it will fatigue or not. So all these factors will decide whether the gaze evoked nystagmus is physiological or pathological. Once we decide it as pathological, then we should differentiate the nystagmus is jerk or is it pendular type based on the crossing of the midline. Suppose it crosses the midline, it will be pendular in nature. If it doesn't cross the midline, it will be jerk. So once it is decided as jerk, we have to find out the trajectory. So the common trajectories are horizontal, vertical and torsional. In vertical we can say it as upbeat or downbeat, and torsional and vertical are always suggestive of central lesion. That is, the damage will be either in the vertical movement control center or it will be in the cerebellum. Where horizontal trajectory type of nystagmus can be present either in peripheral lesions such as vestibular lesions, or it can be present in the central lesions which will control the horizontal eye movements, that is PPRF or again cerebellum. Coming to the saccades, once there is irregular non-rhythmic movements and the initial shift is suppose fast, we have to decide it as saccade. Then we have to carefully observe for the interval. If there is interval in between the saccades, we can consider it as square wave jerks. And if interval is not there in between saccades, it can be either ocular flutter, which will be commonly in the horizontal plane, and if the plane is in any direction, it can be opsoclonus. Important site of localization in case of saccades is it is nothing but just a sort of abnormal movement. So the movement control center, that is basal ganglia, will be involved commonly in the saccadic lesions. So saccades are commonly seen in some conditions such as idiopathic Parkinson disease, progressive supranuclear palsy, multisystem atrophy, and sometimes also in the cerebellar lesions. So this is the overall approach. Coming to the treatment of nystagmus, there are some medications which can be used, such as memantine, gabapentin, 4-aminopyridine, chlorzoxazone, clonazepam, baclofen. Overall, all these medications will try to suppress the central nervous system to control nystagmus. So, the common side effects seen are drowsiness, weakness, fatigue, insomnia, headache, and nausea. Thank you.